co-chair is Professor Tayyaba Gul. She might be running late, but we're starting the session and on medical retina. Our first presenter is Dr. Irfan Karamat, but since Professor Tariq Aziz Saab would like to take the first session, so I would request him to take the first talk. Thank you.
Can you hear me? Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, this is my, I've changed my presentation and because of two reasons. Number one, that we have lost our very dear colleague Azam Khan recently in Karachi. He was, he's the one who introduced anti-VEGF in Pakistan, first time. Macogen came to Pakistan in early 90s, late 90s, and he's the one who gave first anti-VEGF in Pakistan. And the first recipient was General Musharraf's mother. We lost our dear friend, and I know him very well. And the other person that we have lost, that Medical Retina Association of Pakistan, is a now sister organization with Euroretina, and we have also lost the sitting president, Ramin Tendiani. We have also lost, he was a sitting president, and we also lost it few weeks back. So ladies and gentlemen, please recite the Surah Fatiha for the departed soul for the Azam Ali, and after that 1 minute silence for Professor Ramin Tandiani. Thank you very much. Now I'm coming to my presentation. This is a very burning hot topic nowadays, is the geographic atrophy. We deal with every day, but let me tell you very short what it is and what treatment has come up recently. FDA has approved the first medicine how to treat the geographic atrophy a few months back. This was a major breakthrough in the history of geographic atrophy to deal with. And I will be talking about the geographic atrophy challenges and updates. Geographic atrophy is a chronic progressive disease. Basically, ye hai kya? It's a worst form of dry ARMD. It's a worst form of dry ARMD. It's a relentless, irreversible eye disease, and it's, as I said, it's an advanced form of dry ARMD. And geographic atrophy, it develops very, very slowly, and it's very devastating and very frustrating. Usually it's in bilaterally, but it is more worse in one eye and then the other eye. What are the challenges? The best thing, the fundus autofluorescence is a most popular non-invasive modality that we use. And one of our member, her name is Roella, she has also published a book on it, fundus autofluorescence, and I've seen that book, and she's also presented very good pictures of geographic atrophy. Currently, there are about more than 5 million people worldwide, they are suffering from this disease. It's usually, as I said, bilaterally, 48 to 65% of the cases. Usually the geographic atrophy is about 250 micron in diameter. It is usually maybe round shape, oval shape, or maybe inverted U shape, and it usually have got a very sharp delineation. I will show you the pictures step by step how to recognize the geographic atrophy. Hypopigmentation and depigmentation in the retinal pigment epithelium and choroidal vessels are clearly visible. And this is the pattern that you will see the geographic atrophy that it progresses. And at times it leaves a very small macular area that the person can see, but the rest he cannot see around it. This is the typical geographic atrophy, and you can see the clear delineation around the lesion with hyperpigmentation. This is the worst form, and this is the mild form of the geographic atrophy. And as you can see, there is a delineation, very small area, spared area of the macula that he can see through it. And usually it presents with the atrophy of the outer retinal layer and retinal pigment epithelium with the translutation through the choroid. This is the, if you look at the OCT picture, it looks like this. As you can see, the fundus fluorescent angiograph and the typical geographic atrophy. And as you can see, the inverted U form of geographic atrophy. On fluorescent angiograph, the geographic atrophy appears as a sharply delineated window defect due to atrophy of the overlying layer of retinal pigment epithelium, as you can see in this case. This is the typical fundus autofluorescence. This will give you a very sharp, clear picture of geographic atrophy. आप इसको miss नहीं कर सकते. And this is what the fundus fluorescent angiography presentation. These fundus emissions show early left advanced geographic atrophy on the left side and the mild form on the right side, as I showed you earlier. Photoreceptor degeneration as a marker of geographic atrophy progression, and the tracking of the photoreceptor morphology changes along with the autofluorescence pictures and the retinal pigment epithelium changes that you have to follow very carefully. But not necessarily that you can rely on the fundus fluorescent geography. Instead, you have to turn to the OCT as well, which is capable of assessing the RP morphology in the high resolution details. You can take a help with the artificial intelligence. आजकल हर कोई artificial intelligence की बात कर रहा है, कोई कह रहा है कि बड़ा fraud है, कोई कह रहा है ये है, कोई वो है. But in medical fields, it's helping us a lot actually. And but having said that, you have to be very careful that you should not rely purely on artificial intelligence. We have to be very careful. Do not rely on there is a wave, but we need to learn how to surface it, artificial intelligence. There are treatment plans how to deal with the geographic atrophy. As it is very slow progressive disease, doesn't stop or reverse. You cannot reverse this disease, even with the current medication, but you can slow the process of this disease. Remember that it works best when treated initially in the initial stages. An extrafoveal lesion, usually they benefit the most. Safety is a paramount because mostly the central vision that it affects. We must consider the patient modalities, that either you are using these drugs monthly or every other month. Every other month dosing is better because you can prevent the ischemic optic neuropathy or choroidal neurovascularization. How the era of geographic atrophy therapy will unfold. It's only time will tell us, and with the experience, whether this new drug, which is introduced by Apellis Pharma, this is the drug. It has been recently been approved. It's Cybofer, its name, and it cost about just over $2,000 per vial. It is currently only available in United States, and I don't think it is available in the Europe currently or elsewhere. It's what is this medicine? It's a synthetic pegylated complement C3 inhibitor, and this complement C3 inhibitor we use in laboratory to prevent hemolysis of the RBCs. I am very happy to see that this first treatment of geographic atrophy, it's certainly a historical moment for us, and I'm truly looking forward to more therapeutic options that will come available for the geographic atrophy, perhaps earlier than dry ARMD in the future. So you can ask the question on this later on. I think we should carry on with the rest of the presentation. Thank you very much.
Thank you, sir. So the next presenter is Dr. Sidra Riaz. I would request her to come for her talk. Thank you.
Assalamu alaikum. I am Dr. Sidra Riaz and I am working as Professor of Ophthalmology at Akhtar Said Medical College, Lahore. I will discuss one of my study where we studies the factors affecting the diabetic poor control, especially among poor patients. Poverty, is poverty a problem for us? Yes, poverty is a problem for us, and when this poverty is combined with diabetes and diabetic patient with poor knowledge, then it becomes more than a problem. Disease burden is increasing, and in last 2 decades, previously we were at 7th number in diabetic patient population, and now we are at 3rd number, and only India and China are at first or second number in countries with highest concentration of diabetic patients. And as it is a microangiopathy, so at the same time it is a big problem systemically for patient where eyes, kidneys and heart all are affected. Diabetes, poverty and decreased knowledge all are contributing to this with poor control of this disease. Most of the patients, they are very afraid of checking and pricking to check regularly their sugar levels. Our OPDs and OTs, they are already filled and overburdened with the patients. So in our study, we found that most of the patients, unlike the data from all the other worlds where the male were more affected with diabetes, in our studies, the diabetic ladies were more in number who were attending the OPDs for some eye disease as compared to males. Cystoid macular edema was the biggest problem by which that was the presenting plate by most of the patient. Hemoglobin A1C range, the test we have seen among patients was around 5, and maximum range we have seen was 12. Patients were very afraid to take insulin, and most of the patients were on oral hypoglycemics, and there was poor compliance of the drugs. If we check the reasons why the patients who are diabetic, they have poor control of the diabetes, because there is a mixed picture with multiple myths and facts which are contributing to the poor control. One of the myths is that insulin is only the drug where disease is uncontrolled. Rather, insulin को number 1 option होना चाहिए patient के लिए. लेकिन हमारे ज़्यादातर मरीज़ ये सोचते हैं कि इंसुलिन सिर्फ उस मरीज़ को दी जाती है जिसकी डायबिटीज़ वर्स है, हालांकि ये प्राइमरी कंट्रोल के तौर पे देनी चाहिए। प्रिक से हम सब डरते हैं। देयर आर सर्टन मिथ्स एंड सर्टन फैक्ट्स वी मस्ट नो। आपने ऐसी एडवर्टाइजमेंट अपने इर्द गिर्द बहुत सारी देखी होगी। दम वाला पानी बिक रहा है, टैबलेट्स बिक रही हैं, दवाइयाँ हैं, टीके हैं, जो एक ही खुराक में शुगर को जड़ से ख़त्म कर रहे हैं, और ये और भी ज़्यादा ख़राब कर रही है डायबिटिक पेशेंट की सूरत हाल को। I would like to share the 4 myths which are common, yet diabetic patient must avoid all type of sugar. No, they can have sugar, but in limited quantity. You have to cut down on all carbohydrates. No, you can, but with you can consume the whole grains actually. Another myth is that there must be a special diabetic meal for all diabetic patients. It is also contemporary to the facts, and a high protein diet is best for diabetic patient. It is also a false statement. There are 4 major factors which we have studied. Number 1 factor is that there is lack of true knowledge of understanding. There is not lack of knowledge only on patient side, there is lack of knowledge on doctor side too. हमने बहुत से मरीज़ ऐसे देखे हैं जो स्पेशलिस्ट से चेक करवा के आए हैं और उनको ये अंदाज़ा ही नहीं है और उनको किसी ने ये बताया ही नहीं है कि आपने अपनी फंडोस्कोपी एनुअली करवानी है। ये हमारा जो जीपी है उसका भी कुछ कसूर है, और डॉक्टर्स के तौर पे, ऑप्थेल्मोलॉजिस्ट के तौर पे हमारा भी, और मेडिकल स्पेशलिस्ट का भी, कि हमने पेशेंट को ये नहीं बताया कि सिर्फ शुगर कंट्रोल करना काफ़ी नहीं, आपकी एनुअल फंडोस्कोपी होनी चाहिए। नंबर 2, ओनली कार्बोहाइड्रेट्स आर अवेलेबल। हम वो डाइट फॉलो नहीं कर सकते जो कि यूजुअली एक कंप्लीट डाइट है जिसमें फ़ैट, प्रोटीन और कार्बोहाइड्रेट सब कंपोनेंट है। हमारे पास ज़्यादातर लोग सिर्फ ईज़िली डाइजेस्टेबल कार्बोहाइड्रेट्स जैसे गंदम, आटा, आलू इसके ऊपर चल रहे हैं। ये भी एक फैक्टर है। अफोर्डेबिलिटी और इंसुलिन स्टोरेज एक प्रॉब्लम है, और ये प्रॉब्लम और बढ़ जाता है जब लोड शेडिंग भी इसके साथ शामिल हो जाए। पॉवर्टी तो एक एलिमेंट है ही है। देन व्हाट शुड वी डू? देयर इज़ ए टीम वर्क अप्रोच विच इज़ रिक्वायर्ड टू डील विद सच प्रॉब्लम, in which there is 20-20 contribution by the government and society, and major contribution is by our doctors. Our general practitioner and our medical specialists, their role is very vital, and every diabetic patient must be referred for fundoscopy annually at least. And as ophthalmologist, what we can do is that we can educate the patient about good diabetic control, that is hemoglobin A1C below 5. There should be annual fundoscopy. At least patient should know that he or she needs annual fundoscopy. Number 3, the patient education regarding other treatment option which can prevent or delay or cure the ocular complication like laser and anti-VEGF. There is a vital role in controlling the hemoglobin A1C, that is 3-monthly test, and diabetic patient also need to control their liver function and renal function, and regular checkup is a must. So diabetes is not a little disease which can be cured with some insulin or oral hypoglycemics. It is a systemic disease. So the multidisciplinary approach is must, and we as a doctor should educate our patient how to control and how to maintain a good optimal control of diabetes. Thank you.
Thank you so much, Dr. Satra Riaz. Just a little announcement. There's an award presentation by MRAP at the end of the session, so kindly remain seated. Next presenter is Professor Shahid Jamal Siddiqui. I would request him to come to the stage. Thank you.
Start over. Bismillahirrahmanirrahim. You know that everybody is aware about central serous chorioretinopathy. And since long, we are studying how we can we can improve the vision of these patients, and we can prevent the recurrence of these patients. So, this is the study of the visual outcome in the cases of CSCR after this acetazolamide and eplerenone administration. Central serous chorioretinopathy, as we all know that it is a neurosensory retina, detachment of the neurosensory retina at the posterior pole, and retinal pigment epithelial detachment or dysfunction, choroidal hyperpermeability, and self-limited spontaneous resolution within 4 months. It can be roughly categorized acute and chronic. Acute CSCR usually resolves spontaneously. Chronic can lead to irreversible deterioration of in vision, in visual acuity, and contrast vision and quality of life. And it is common in young individuals, and these young individuals is the working class, working people of our community and of our country or in the world, and they suffer from a sudden decrease of the vision and severe disturbances of the vision. Now, presentation we all know, it is nothing to describe. I want to highlight that what we have done up to now to improve the visual acuity as soon as possible. We have seen that the people are suffering from reduced visual acuity for 3 to 6 months, but we want to resolve it so that it could be improved within 1 month or few days, so that the person becomes relaxed and start working you can see actively. Now, these are the treatment options. Usually researchers on spontaneously resolution and observation is very important. ये नहीं चल रहा क्या? यहाँ से करो. Okay. Now, usually resolves spontaneously. Observation, discontinuation of the steroids if the patient is on steroids due to any disease, reduction and avoidance of stress. Acetazolamide and eplerenone has been used by ophthalmologists, and I myself have used acetazolamide, and my article was published in the journal, and now I am also comparing the acetazolamide and the eplerenone efficacy in the central serous chorioretinopathy. Acetazolamide enhanced subretinal fluid absorption and increase in retinal adhesiveness by causing acidification of the subretinal space. It inhibits gamma-glutamyl transpeptidase activity in ocular tissues and facilitates cellular adhesion, neutrophil chemotaxis, and degradation through elevation of leukotriene D4 concentration. Now, these are the results. 53 patients were there, 42 male, 11 female, number of eyes were 54, and age group was from 19 years to 52 years, and average age was 33 years. 52 cases were unilateral and 1 case was with bilateral CSCR. In this group of the patients, the treatment was given acetazolamide, 250 milligrams BD for 4 weeks and 125 milligrams BD for 4 weeks. And another was the control group, which was not treated with any medication, and placebo medicines were given to these patients. This was the result, and visual acuity improved in these patients. Initially, it was less than 6/60 before treatment in 6 patients, and then you can see in last, it was 6/6 in 27 patients after the treatment of acetazolamide. Now, this is one of the patients who got acetazolamide and improved the visual acuity. Visual acuity was improved. Initially, it was in the left eye 6/60, and near vision was N18. In this picture, this is the picture of the same person. Visual acuity in the left eye was 6/6, but in near vision also improved to N6 with the treatment of acetazolamide. Now, this is another patient with central serous chorioretinopathy. Initially, visual acuity was 6/24 and near vision N18, less than N18, and it improved to 6/6 and N6 with the treatment of acetazolamide. I mean to say that when we say that chronic CSCR, which takes more than 4 to 6 months, and acute CSCR, which is from 1 to 4 to 5 months. This is the treatment group. Duration of subjective improvement and clinical resolution was 15 days to 1 month with the treatment with acetazolamide. And recurrence was seen in 1 patient. Eplerenone, the treatment group was of 5 patients. Unilateral were 5 and male 4, female 1. Male preponderance is there, and number of eyes were 5. You can see this patient. This patient is same Ali Arshad, who I showed you when he took acetazolamide and it was improved. But here again there was recurrence. This is the patient who developed recurrence of central serous chorioretinopathy. Then we started, and the visual acuity in the start was 6/18. We started with eplerenone, and it became 6/6. But you can see that the subretinal space is still empty with fluid. So there was, you can say, the slow absorption of the subretinal fluid as compared to the treatment with acetazolamide. This is another patient who presented with 6/18 and near vision N18. And after the treatment with eplerenone, the vision was improved, 6/6 and N6 on near vision, but still the subretinal space, the fluid is there. So coming to the conclusion, central serous chorioretinopathy, acetazolamide shortens the mean time of visual improvement and accelerates clinical resolution. It has no influence on the final visual outcome, but it is more effective in resolving the subretinal fluid. Eplerenone, for acute CSCR, there is accelerated resolution, visual acuity improves, but in subretinal fluid, which occurred in comparison to placebo, a good difference in best corrected visual acuity was noted. Eplerenone is effective mode of treatment for CSCR. Now, means that acetazolamide, the visual acuity was improving, but the subretinal fluid was also, absorption was also taking place. In eplerenone, the visual acuity improved, but the subretinal fluid absorbed, but in later stages. PDT remains the best option to treat CSCR at any stage, especially subfoveally. High density subthreshold micropulse retinal laser treatment with diode laser. Long-term follow-up studies are required to decide more safe and effective mode of treatment, prospective and retrospective. Thank you very much.
Thank you, Prof. I would request the speakers to kindly speed up a little because we are running out of time. Now I would request Dr. Irfan Karamat to have his talk. I believe one of his residents is taking the talk, Dr. Mujibur Rahman. Thank you.
यहाँ से ठीक है। Assalamu alaikum. My name is Dr. Mujibur Rahman. I am a resident of ophthalmology at Jinnah Hospital, Lahore. I am here to present a novel approach for the management of refractory diabetic macular edema. As we all know that it is a retinal thickness caused by accumulation of intraretinal fluid primarily in between the inner and outer plexiform layers, and it is believed to be as a result of hyperpermeability of retinal vasculature, and if not responding to conventional treatment, we may regard it as a refractory type. Macular edema, as we know, diabetic retinopathy is the leading cause of macular edema. And with current diabetic medications, lifelong risk of developing diabetic macular edema is still 20%. Retinal vascular disorders, 30% of patients having CRVU develop macular edema. Uveitis, particularly panuveitis and posterior uveitis, lead to macular edema. Pseudophakic macular edema, choroidal neovascularization, drug-induced intraocular tumors, CSCR, radiation retinopathy. These all are the leading causes of macular edema. Refractory macular edema. In general, we don't have any definitive definition for refractory macular edema, but for diabetic refractory macular edema, we take it a patient having at least 6 doses of intravitreal bevacizumab and ranibizumab, and then switching to aflibercept, and for after 3 doses of intravitreal aflibercept, still on OCT we have macular edema of 350 microns. So we regard it as a refractory case of diabetic macular edema. Pathogenesis, as we all know, metabolic changes and inflammatory reactions in diabetic patients can lead to loss of endothelial tight junctions and result in blood-retinal barrier dysfunctions. So we can see that both inner and outer barrier are disrupted in diabetes, which lead to macular edema. Mediators involved are vascular endothelial growth factor, transforming growth factor B, tumor necrosing factor, interleukin 6, carbonic anhydrase isoform 1 and 2. They all lead to be mediators responsible for diabetic macular edema. Treatment options for such cases, we can switch between anti-VEGF agents. We can go for suprachoroidal corticosteroids. We can go for combination therapy, and we can even try vitrectomy. Even vitrectomy for refractory diabetic macular edema is not ideal, because after vitrectomy we know that resolution time enhances many folds. In combination therapy, we can go with anti-VEGF and combine them with grid laser. We can go with anti-VEGF with subthreshold laser, steroid plus threshold lasers. We can go with suprachoroidal steroid with intravitreal anti-VEGF. We can combine steroid with vitrectomy, PPV plus limiting membrane peel. What we propose is a novel approach in which we combine intravitreal anti-VEGF. Here we basically change the agent, anti-VEGF agent we change. We will go with suprachoroidal steroid in a dose of 4 ml in 0.1 ml, oral carbonic anhydrase, 250 mg BD for 4 weeks, and topical non-steroid anti-inflammatory drugs in a higher concentration of 0.3%. In our study, basically there were 10 patients which were enrolled. They were in age group between 50 to 65 years, 6 were male, 4 were females, and every one of them had at least 5 doses of intravitreal bevacizumab with 1 month interval. 5 of them were pseudophakic and 5 were phakic. There was no evidence of any advanced diabetic eye disease or any other vitreoretinal comorbidity. We gave them this tetra regime, and we followed up for 4 to 6 months. Visual acuity was recorded, and at 20 weeks interval, post-treatment regime OCT was done. This is OCT of patient 1, as we can see in upside image, central thickness was more than 850 microns. And after 1 month of this tetra regime, the macular edema settled and thickness remained in between 230 micrometers. This is OCT of second patient. Here we can see that it is giving an impression of vitreomacular traction. In fact, the case was non-diabetic patient, and when we gave him this tetra regime, it came out that edema settled, and it was basically vitreomacular adhesion and not traction, which was giving this impression in OCT. This is case 3. OCT of patient 3, and here we can evident that macular edema settled. In case 4, again, there was a central thickness of more than 800 microns, and which remained to about 270 micrometers after 1 month of this tetra regime. We propose that this is a novel approach, as we all know that these drugs, they have different pathways for managing diabetic macular edema. But different studies have suggested that they have additive effect. They do work in synergy and improve, add on in their effect for managing diabetic macular edema. So we suggest that this trial should be done in a large scale of population, and its effectiveness and safety should be tested in large group. Thank you.
Thank you, Dr. Mujib. I would request Dr. Irfan Karamat to kindly present his talk. Thank you.
Bismillahirrahmanirrahim. I'm Dr. Irfan Karamat, and today I'm going to present autologous platelet-rich plasma for macular edema in retinitis pigmentosa. RP was first described in 1855. It's a disease of vascular leakage and increased retinal permeability, which worsens in trauma and surgery. Its prevalence is different in different geographic areas. It's basically a disease of outer retina, with early histopathological studies shows that it's a disease of outer photoreceptor. It disturbs photoreceptors, primarily the outer segments of rods. And in advanced cases, even cones are involved and central vision is disturbed. Earlier, two-stage hypothesis was tossed, in which in stage 1, there were no clinical findings. Just there was no visual change or visual retinal abnormalities. And in stage 2, we can see that there were clinical findings along with symptoms as well. This was this hypothesis which was tossed earlier in early 1900. In modern era, the concept is tossed that initially there's no disturbance in rod and cones. Initially, rod and cones are healthy. When the disease advances, the rod and cones goes into a dormant phase. And after the going into dormant phase, if disease further advances, it goes into apoptosis, and patient have grave loss of vision. What we propose and what we did, that when we injected autologous platelet-rich plasma in those patients through subtenon space, those dormant rod and cones switched back to healthy rod and cones, and they have their normal function, which gave into improvement in visual acuity and visual functions. If you look at this micrographic picture, which is taken from Ryan, that part of this picture is showing that the outer segment of rod and cones, I hope the picture is clear, if not, I can just describe it for you, that the outer rod and cones or ISOS junction is disturbed, which is got compared with the healthy retina. If you see, this part is the healthy retina or outer rod and cones, which is far more better or greater than the diseased one, which you can see in that part of the picture. In patients of retinitis pigmentosa, 8 to 58% of the patients are affected by macular edema, which is considered because of the disruption of the outer retinal barrier, that is RPE. What we propose and what we believe that autologous source of PRP, when given subtenon, it improves RPE function. And when it improves RPE function, what it does that the fluid which is present in the retinal layers, which starts getting absorbed, and this macular edema gets resolved. This is a study which got published in 2018, which showed that the subtenon route is quite effective in improvement of best corrected visual acuity, visual function, and multifocal ERG. In this, our unpublished data of subgroup, macular edema was monitored using OCT before and after injection of subtenon autologous platelet-rich plasma. And what we see that significant improvement was seen after the treatment in the patients. This is a first example. In this, the upper part of the picture shows that there are cystic spaces in the macular area of the patient, which after given 3 injections, there are no cystic spaces, which you can see that in the lower part of the picture that are all gone. This is just 9 weeks follow-up. This is patient 2, in which again autologous subtenon platelet PRP was given, and you can see that there's a significant change in cystic spaces of the retina in the macular area of the patient. Another patient, again showing a significant improvement in visual acuity, central visual acuity, and along with that, there's an anatomical change in which the cystic spaces are almost gone in the parafoveal area, just after giving 3 injections of PRP in subtenon space with a gap of 3 weeks. This is another study which compares subtenon and suprachoroidal route for autologous PRP, showing very favorable results. And apart from the results, the best part is that this route is with zero complications. It's an absolute safe regime or absolute safe strategy to give PRP or regenerative modality. So delivery of autologous PRP via subtenon route remains a safe and effective approach in patients with retinitis pigmentosa for treating macular edema. The delivery of molecules to the retina via this route is affected by various physiological barriers, which includes scleral thickness, choroidal blood circulation, and blood-retinal barrier. Thank you.
May I request our co-chair, Zubaida Sarang, to present safety of nurse-led intravitreal anti-VEGF injection, please.
Thank you so much. Thank you, Professor Tariq Aziz, and thank you, Professor Shakib. I'll be talking about safety audit of nurse-led intravitreal anti-VEGF injection. Since we are running a little out of time, so I'll be a little quick. Bear with me. Thank you. So we did this survey in Ireland 2 years ago, and to do the introduction, intravitreal anti-VEGF is used for previously untreatable conditions like wet AMD, diabetic retinopathy, and retinal vein occlusion. Mostly patients require multiple injections over the period of time because it's an ongoing thing. That leads to increased workload and longer waiting period for the patients. So increased workload for the physicians and waiting period for the patients. So what we did was they introduced this nurse-led injections that were given by the trained ophthalmic nurses in Ireland, Dublin, Ireland, and no similar audit was done previously, so we did the audit. It was a retrospective survey we did in Mater University Hospital, Dublin, where I was getting trained. It was done during July 2019 to July 2020. There were 2 trained ophthalmic nurses who were doing the injections, so those were in the survey. There would be supervisor ophthalmologists who would be in the close vicinity. The injecting nurse and the assisting nurse would follow all the guidelines. So regarding the guidelines, they would just follow the standard protocol, like disinfecting the conjunctival sac and periocular area. Antibiotic eye drops were installed soon after injection, but there was no eye drop that would be given after injection, and no regular follow-up was done. Gross vision was checked soon after the injection. So what we did was we went through the charts for intra and post-operative injection complications, as well as the ER visits for the patients. Coming to the results, total 1,782 injections were administered during this time period, because it was a large public sector hospital and it was free for the patients, so there were lots of patients, but we didn't come across any kind of, no cases of endophthalmitis, retinal tears, vitreous hemorrhage, or retinal detachment were noted. Only 1 patient had acute loss of vision because of the increased intraocular pressure, and that needed ophthalmologist's intervention at that time, and he was fine afterwards. Only 1 patient had corneal abrasion who presented with ocular pain afterwards in the emergency, and she was treated. There were 12 patients who had subconjunctival hemorrhage, and there were no systemic complications. This just showing the complication rate. There was no endophthalmitis, no retinal detachment, no lens damage, no vitreous hemorrhage. Coming to the discussion, our data shows that suitably trained nurses, ophthalmic nurses, can safely inject intravitreal anti-VEGF injections in a larger public sector hospital where there's a huge workload on the ophthalmologists. In our data, the complications were low, and that were comparable with previously published data. We can safely introduce even in our part of the world, and it can have positive impact on the medical retina service. Thank you so much. Thank you.
Thank you, Zubaida, for your enlightening presentation. Thank you so much. Last but not the least, I will request our sitting president of MRAP, Dr. Shakib Anwar, to present his presentation. Please, thank you. Please remain seated. There will be a word presentation by the MRAP soon after this session.
All right, Bismillah ar-Rahman ar-Rahim. Full picture mode kar le. Worthy founder president, Mr. Tariq, co-chair, worthy audience, ladies and gentlemen. We always keep treating age-related macular degeneration, and at the end we always conclude that we do not have a real treatment for it. And why should we have? It's an aging process. And whatever the other things may be, but if the main determinant of the course of a disease is aging, how can we really stop it? It has to deteriorate, right? So we can treat the sidelines, the superimposed things, edema, hemorrhage, but we can't change the course of the disease. Although there is some work is being done on the genetic side, yeah, but it is still in the offing, it's still in the way. So I had collected a few cases which I could follow for at least 2 years. And then I have compared it with an international study that how those behave in the real world when they're treated at good regular, almost regular intervals with anti-VEGF treatment, and they are followed on OCT. So there's a study, it was done in Italy, and it was published in July 2023 in the journal Retina. So what they did, so it is probably the, So it is probably the only known real-world study done. And what they did, that they divided the visits and the recording time into 5 phases. They recorded the vision of the patients who were intravitreal injection naive. They were not treated. Then the pre-visit, that the last injection which was done before a significant fall of the vision. Then the baseline visit, which was done at the time when the patient reported with loss of vision, and then 3 months, 6 months, and later on. What they found, that in treatment naive patients, this period before the start of the loss of the vision and up to the baseline, it was 34.3 weeks. And the patients who were not treatment naive and they were getting some treatment before, they had this period only about 9 weeks. So it was concluded that the patients who were treatment naive and they are started with the regular treatment and followed through properly, they have a better visual outcome as compared to the people who have got some treatment from somewhere and it's not regular even, they have a worse prognosis. They found that about 6% people had a sustained loss of vision. वो ठीक नहीं होता. 25% had an abrupt loss of 15 letters or more, and 59 had no recovery even after 4 weeks of intravitreal injection. And we keep on seeing these patients. When we do it, we see that every patient doesn't behave the same. And it was also found that it was not unusual in real world for this kind of loss of letters to occur between 2 consecutive intravitreal injections, often within 9 months of diagnosis and 2 months after the last IV. Density of reflective material as seen in OCT can be a predictive marker. So when we see the OCT, we can tell that this patient is going to get a little better and this is not going to get benefited. So we can have a little insight into it. So the patients who had the pre-visit, you can see with a good vision of 6/9, they had a minimal fibrotic lesion here. 8 months after this pre-visit, the patient developed highly reflective substance. There was intraretinal and subretinal fluid also, and some loss of retinal. There was a blockade and maybe some disruption of the RPE complex. 3 months after the baseline, when he had already lost the vision, you can see that it is not improving, and he has also got some cystic degeneration developing in the intraretinal layers. Now, if we see it on a standard, we see that there are certain hyporeflective depositions, and they are matchable to the nuclear layer. So this material, which is matchable to the nuclear layer of the retina, we call it hyporeflective. And there is another which matches with the plexiform layer, we call it isoreflective. And the one that matches with the retinal pigment epithelium density, we call it hyperreflective. And then we can predict the prognosis. Fibrin and hemorrhage, they constitute the hypo and isoreflective material. If it is undefined, then it is fibrin, early neovascular AMD, and if it has a defined margin, then it is hemorrhage. So you can predict they have a better response. But if you see something like this, hyperreflective, then its neovascular or fibrotic issue component is more, and it is unsatisfactorily responsive to the treatment. So from here, the pathologies that we can see in these areas are subretinal fluid, intraretinal, and a hyperreflective foci, and disruption of external limiting membrane, ellipsoid zone, and interdigitation zone, which are very important for us in this. All right. So this is my patient. So I chose a patient who had a better compliance and used to come early, and he was able to get the OCTs also done. We have a problem that's a costly thing. So sometimes patient does one OCT or two maybe, and then he doesn't do it, unable to do. So this is the patient who came in May 2022, and he had a vision of 1/60 in the right eye, you can see, and 6/12 in the left eye. You can see some hard material, little cyst here, and fibrotic material. Retinal pigment epithelium complex is relatively okay, not much broken. At places we can see that there's a rainfall here, so there might be some disruption, but rest is fine. After 2 months of injection, so he got it done from, I have hidden his name and that thing. So after 2 months, there is slight betterment. You see the cyst is gone on the left side, and it's slightly better. This area on the right is also better. The vision improves to 262 and 69. 2 months again, 4 injections done, still better, or at least maintaining the vision. After about 6-7 months again, he had 2 more injections in between, and I had raised the gap to 8 weeks. Now I am giving at 8 weeks, not at every month, and we still see that vision is maintained well, and he's getting better on left side, but still a lot of edema on the right side and some fibrotic element. Now this is real world study. This is my real patient. Then he got away. For 5 months, he was away. He thought he is okay. He didn't come for 5 months, no injection for 5 months. So see, a little disaster coming again. A cyst is developing here, and the vision drops to 6/12 and 2/60 again. Thoda sa hosh aa gaya usko, and he started getting the treatment again. And then it started improving to back to 2/60 and 6/9. And then he's on the road, and this is yesterday. By chance, he came to me yesterday, and I was able to take this picture yesterday and added. Now see, he's corrected, best corrected vision is 3/60. On the right side, you see, he's not that bad now, and on the left side is 6/9 plus. I had operated on the left side also. Intraocular lens was implanted about 6 months ago. So see, it's quite okay on this side. Now, if we compare them together, we keep them together. 2 years back, he was like this. 1 year back, he was like this. And now he is like this. You see, the central part, even on the right eye, is so good, and left eye is quite fairly well. And if we put all them together, if you compare this one 2 years ago with this one 1 year ago, and this one with today, he has made a lot of improvement. At least he is maintaining his vision after 2 years. And he had about 9 to 10 injections on both eyes. So patients who do the best in the treatment are the treatment naive patients and those presenting early. And those who avoid longer intervals, especially in the first year, and who maintain healthy diet and healthy lifestyle, and who maintain good control over BP and diabetes and use of oxidants and vitamins. This is my experience that they do better. And those who do worse are more fibrotic element, exudative fluid, and those who have degenerative intraretinal and subretinal fluid, different treatment regimes and bad compliance, and more than 8 weeks of interval in the first year of treatment, and those who have sporadic or abrupt loss of vision. So take-home message is, in the real world, it's not unusual for the patients to lose substantial vision even between consecutive IVIs. A very close watch at the course of the disease during follow-up and critical analysis of OCT can predict, and one can make a decision for the treatment and also counsel the patient. Thank you very much.
Thank you, sir.
Thank you very much, everybody. A very good session. And as a tradition, Medical Retina Association of Pakistan always give the leadership award to some budding talents in Pakistan. And traditionally, we have been presenting these awards once a year to the best leadership in our medical retina. So the first award goes to, again, we have given so many awards, but majority of them goes to the girls so far. I don't know why. ये हमसे ज़्यादा पढ़ी लिखी होती हैं, ज़्यादा समझती हैं, रिसर्च ओरिएंटेड करते हैं, और जो मर्द हजरात होते हैं वो होते ही घामड़ हैं, कोई लफंट्री करते हैं, पढ़ते नहीं हैं, सब कुछ करते हैं. But the girls, they are really doing very, very good, no doubt about it. So this year we have got a few awards. The first award goes to another lady, and she is very research oriented, very hard working. जितना उसने OCT पे काम किया है, मैं समझता हूँ हमने भी नहीं किया, and we always learn from her. And she's and most important thing that her contribution in Oxford Handbook of Ophthalmology is noteworthy. यानी कि हम लोगों ने अभी तक कोई कंट्रीब्यूशन नहीं किया. आई थिंक उसने जो कंट्रीब्यूशन किया है, वी शुड रिकग्नाइज, एवरीबडी शुड क्लैप दैट. एंड not only that, and her contribution in research in OCT is remarkable. वो जिस तरीके से जो presentation देती रहती है हमारे WhatsApp group पे, that's really very, very impressive. No doubt about it. So this award goes to Hina Khan, works in Amanat Eye Hospital. I request Amir Yaqub to give this AMRAP leadership awards to Hina Khan. I think we should break the tradition. The second award goes to a gentleman, which I know him for many, many years. He was my trainee. He was trained under me in the medical retina. And after the training, he moved to Larkana. And then he managed to establish the medical retina department in Larkana. And successfully, he's been conducting since the medical retina symposium in Larkana from the day one. The only day that he's not been able to do that during the break of COVID. So, ladies and gentlemen, leadership award goes to Professor Shahid Jamal Siddiqui. I will request Amir Yaqub, who is a sitting president of Rawalpindi branch, to present this award to Professor Shahid Jamal Siddiqui.
Yes, we are done. Thank you so much, ladies and gentlemen, and congratulations to Dr. Hina Khan and Professor Shah Jamal. Thank you so much, Professor Tariq. Yeah, we are going.